Then coming to the next gland, thyroid gland. This gland has influence from both the pituitary and hypothalamus. For example, the thyroid stimulating hormone comes from the pituitary, anterior pituitary, and this is stimulated by the thyroid releasing hormone from the hypothalamus. But the final action is not happening there. The final action happens in the gland. It has to come to the thyroid gland and stimulate the thyroid gland. That's why we are discussing it under thyroid gland. The thyroid gland has two groups of cells. One is the follicular cells, and very next to the follicular cells, there is some group of cells called as the parafollicular C cells. And this parafollicular C cells produce one substance called as calcitonin. The calcitonin does not have any role in production of thyroid hormones, but calcitonin is very, very essential for calcium balance. We will discuss calcium hemostasis where its action will be seen. And calcitonin, I'll just mention its important function. It is a calcium lowering hormone. Calcitonin, name itself is the calcium lowering hormone. Don't think this is very bad, because calcium it has to take it from the blood and deposit it in the bones, which is good only. Calcium lowering hormone. This part we will discuss along with calcium hemostasis. Then coming to the thyroid gland, that is the follicular cells. The follicular cells are the ones which is going to produce thyroid hormones, especially the T3 and T4. And what is the difference primarily between T3 and T4? T4 is called as thyroxine, T3 is triiodothyronine. So T3 is the most active form. This is the most active form. The deiodination of T4 can bring it to T3. Deiodination of T4 can bring it to T3. So whenever it is required for action, it will be converted to T3. It is like the stored form. It is like the stored form. And what is the half-life? It has less half-life. It has increased half-life because it is a bound form. It is a bound form. The T3 is the one which is acting. But as a drug formulation, which I should give? T3 or T4? Most of us think it is T3, but the answer is not that. Because when you give T3, the action will be done in seconds. So it's like you have to take multiple thyroxine tablets for the same day. That's why the preparations are made in T4. Because whenever T4 is given, as and when it is required, it can get converted to the T3 forms. So the treatment part is given with the help of T4, that is levothyroxine is nothing but a T4 form. So pharmacological formulations are done with T4. Pharmacological formulations. So that is the difference between a T3 and a T4. So coming to the thyroid hormone formation. The thyroid hormone formation has multiple steps, but we are going to concentrate on three important steps. The first one being the iodide trapping. This is called as iodide trapping. All of us know that for the formation of thyroid hormone, iodine is very essential. That's why they have developed the formulations like adding iodide in the salts, so that it is available for all the patients, especially in countries like where there is thyroid deficiency. So how does it happen? This happens with a symporter called as sodium iodide. Here it is not iodine, it's iodide symporter. This will concentrate the iodide inside the thyroid cells along with the sodium. So once this happens, what will happen? This iodide form will be available inside the thyroid cells, and they will be transported. When you see the thyroid cells, they will have a follicular cells like this, where the hormone, where this is happening, and they will have a central colloid. This central colloid. So now the reabsorption is happening here. Finally, it should be transported to the colloidal area. So from the inside of the cell, it will be transported through a transporter. Along with another thing is produced in the inside the cell. What is that? That is thyroglobulin. This thyroglobulin is also produced inside the cell. It is produced in the endoplasmic reticulum and it is packed in the Golgi apparatus. So this thyroglobulin is also produced and kept. It is like a precursor for T3 and T4. Now two things are available for us. One is the thyroglobulin, which can be directly transported. The second thing is we need an iodine form. That second process is called as iodination. This is called as iodination. The iodide form will be converted to the iodine form, which is I2. So now we have the raw materials. One is available, then thyroglobulin is also available. So whenever these two raw materials are available, then we can form the thyroxine. So this third step is formation, or we can say that thyroglobulin reaction. Thyroglobulin reaction. So this reaction is thyroglobulin reaction. So whenever they combine, they will form MIT. What is this MIT? MIT is nothing but monoiodothyronine. This monoiodothyronine, whenever it combines with another monoiodothyronine, it will form DIT. Whenever DIT combines with another MIT, it will form T3. When two DITs combine, they will form T4. This T3 and T4, whichever is formed, they will be taken back into the cells again by the endocytosis process. Why they have to be taken back into the cells? Because they will be stored inside the cells. So this storage is so humongous that it can survive for 3 months. Even after development of disease, still the patient will be presenting to us after 3 months only. By the time all of them are getting depleted. So this is the extraordinary function of it. So whenever the iodine is transported out, what is happening is it is transported through a specific transporter called as pendrin. This pendrin transports this iodide and takes in the chloride ions. This pendrin does this. This pendrin is also very essential channel. It is also present in the ear. This pendrin protein is also present in the ear. So whenever a patient presents with both, like thyroid hormone deficiency also and deafness also, it is most likely this protein is affected. And there is a specific syndrome named after this channel only, that is the protein only, that is Pendred syndrome. This syndrome is called as Pendred syndrome. So the history will be a thyroid disorder along with deafness. So that is Pendred syndrome. And the most common deficiency, all of us know, it is iodine deficiency in India for the thyroid disorder. Next, we are going to understand the functions of thyroid. So functions of thyroid we will understand. That will help us to understand what happens in hyperthyroidism and hypothyroidism. So coming to the functions of thyroid hormones, the thyroid hormone is the one which is involved in maintaining the basal metabolic rate. So it is the one which is generating lot of heat in the body, and it is the one which is constantly functioning. So for basal metabolic rate, we studied one important channel in general physiology itself, which is nothing but the sodium potassium ATPase channel. This is the one which is consuming loads of energy in the body, and this is the channel which is activated by thyroid. Thyroid hormones act on this channel. And thyroid hormone on metabolism, if you talk, it is universally catabolic. It is universally catabolic. It is going to destroy everything like carbohydrate catabolism, protein catabolism, and fat catabolism. So carbohydrate catabolism, proteolysis, fats converted to amino acids. So everything is catabolic. Then coming to the GAT, it increases the motility of GAT. It increases the motility of GAT. And coming to the cardiovascular system, it is going to increase the heart rate and it is going to increase the cardiac contractility. So these all will be the features in hyperthyroidism, which we'll see. Then CNS, it increases the firing of neurons. Everything is increased. GA motility, CVS action, CNS action. So how will the hyperthyroidism patient present to us? One key feature is that to identify an hyperthyroidism patient. The hyperthyroidism patient will be losing weight because of increasing BMR, will be losing weight. And the key here is in spite of good appetite. In spite of good appetite. He is consuming well, but because his BMR is increased to so high levels, he is losing weight. We might think it is good, but on a longer run, it's not so good because he is losing weight consistently because of the raised BMR. So whatever he eats, it is like it's evaporating up. Okay. Now coming to hypothyroidism, here the patient will gain weight. They are little sad people. They will gain weight in spite of, what is the condition? In spite of poor appetite. Poor appetite. They will eat less. This will be the classical complaint. They will eat very less, but still they will be gaining weight. So that is a case of hypothyroidism. Because in general condition, just remember, most of the cases there is not good appetite. The patient is not eating well. Even in carcinomas, they are not eating well. So they lose weight. And sometimes they eat more, they gain weight. But thyroid is one condition where it is reverse. There is loss of weight in spite of good appetite in hyperthyroidism, and there is gaining weight in spite of poor appetite. So this is a classical clue. Then coming to the GAT, there is increasing motility. So hyperthyroid patient will have diarrhea. Hyperthyroid patient will have diarrhea. Whereas they will have constipation in case of hypothyroidism. Then coming to the next feature, CVS, there is an increase in heart rate leading on to tachycardia. Whereas here the bradycardia will happen. Here bradycardia will happen. Then there is heat intolerance. Already this patient is producing lot of heat. The hyperthyroidism patient, they are generating their BMRs very high. So if you put them in a hot sun, they will not be able to tolerate it because their body is also producing an external environment is also very hot. So they will have heat intolerance. And this will also be a classical history. Some patients will tell, like a female who is young and a little overweight comes to you and says that whenever she moves to a cold temperature, she is highly intolerant. So that is cold intolerance because their BMR is very low. Their body is not producing any heat. So they are intolerant to cold. That is called as cold intolerance. Now coming to the next feature, that is CNS, that is increased firing of neurons. So they will be hyperactive. Whereas in case of hypothyroidism, they will be dull and lethargic. Don't think this hyperactive is good. They will go for exhaustion, easily go exhaustion, and their functionality is obviously reduced. Initially, it might be good, but later on it reduces. So dull and lethargic. So these are the differentiating features between hyperthyroidism and an hypothyroidism. So what is the treatment for hypothyroidism? Thyroxine is given. Then for this, there are various group of drugs like the sodium iodine synthetase inhibitor. Like hypothyroidism, we can give carbimazole, methimazole. Various groups of drugs are available for hyperthyroidism also. Then coming to another important condition that is called as thyroid storm. What is this thyroid storm? Whenever there is a sudden increase in T3 and T4, what is going to happen? The patient will have all the symptoms of hyperthyroidism, but one symptom will be very predominant. They will have tachycardia. So what is the first drug of choice? If you are thinking of prescribing any kind of anti-thyroid drugs, that is not the main concern here. First main concern is to reduce the tachycardia. So don't think about an anti-hypothyroid here. We should always give a beta blocker because my primary concern is to reduce this tachycardia first and bring him to normal condition. Later on, we can definitely give antithyroids to save the patient, like to save the patient from this condition. But the first choice of drug will be a beta blocker. For example, it's propranolol. Most of the students make mistake in this thyroid storm question because propranolol is completely irrelevant to anti-thyroid drug, but still it is the first drug of choice in case of a thyroid storm.